Welcome back to episode 232 of Real Health Radio. You can find the show notes and the links talked about as part of this episode at 7, so the word all spelled out, seven-health.com/232. Hey everyone, welcome back to another episode of Real Health Radio. I'm your host, Chris Sandel. I'm a nutritionist that specializes in recovery from disordered eating and eating disorders, or really just helping anyone who has a messy relationship with food and body and exercise. And this week, the show is a guest episode, and my guest today is Lauren Muhlheim. So Lauren is a psychologist, a certified eating disorder specialist, and an International Association of Eating Disorder Professional approved supervisor who provides evidence-based treatment for eating disorders in the outpatient setting. She works with people of all ages and all eating disorders, including anorexia, bulimia, binge eating disorder, avoidant restrictive food intake disorder, orthorexia, muscle dysmorphia, and male eating disorders. She provides cognitive behavioural therapy, or CBT, for adults and family-based therapy, or FBT, for adolescents, and adheres to health at every size principles. She is certified in FBT by the Training Institute for Child and Adolescent Eating Disorders. She is also the author of When Your Teen Has an Eating Disorder, Practical Strategies to Help Your Teen Overcome Anorexia, Bulimia, and Binge Eating. And this book is an FBT-based book for parents who are helping adolescents with eating disorders. Dr. Muhlheim is active in several professional organizations. She is the eating disorder expert for the website Verywell, which was formerly about.com, and is the clinical director of the eating disorder information website Mirror Eating Disorders. She presents nationally to parents, professionals, and trainees, and she is active on social media and in eating disorder advocacy efforts. You can find her at eatingdisordertherapyla.com. So I've been aware of Lauren for some time now. She is rather prolific in her writing about eating disorders for the website verywell.com, and she's had, or I've read many of her articles there. And in fact, when I was putting together the recent episode I did on brain changes that occur because of restriction, one of her articles was the first one that came up, and it pointed me towards a number of papers that I then referenced in that episode. So as part of this discussion with Lauren, there were three main topics that we covered in a fair amount of detail. So the first is Cognitive Behavioural Therapy, or CBT, for eating disorders. And we talk about what it is, some of the foundational ideas, and how it is used in practice. And as Lauren points out, the name can be somewhat misleading because the word cognitive is in its title, and it's misunderstood that this means talking about beliefs and challenging beliefs with different thoughts, when in fact it's mostly about behaviors and taking action. And I've wanted to cover CBT on the show for a while now because I find it so helpful with clients. So it was great to be able to have this discussion with Lauren. We talk about family-based therapy, or FBT, and what it is, how it works, how Lauren uses it in her practice. And finally, we talk about avoidant restrictive food intake disorder, or ARFID. And this is a lesser-known eating disorder that Lauren is increasingly working on in her practice. And she describes what it is, the three different types of ARFID, and how each of them is treated. And this is an incredibly practical episode, and there's lots of ideas that I believe can be really helpful. So here is my conversation with Lauren Muhlheim. Hey Lauren, welcome to Real Health Radio. Thanks for chatting with me today.
Thanks for having me.
So I'm a big fan of your work. I've read many articles that you've written, and I've heard you on a number of podcasts. And you're someone who's had a long career and a diverse career, working in many different areas and different locations and countries. And you have a real wealth of experience with eating disorders, and again, across a real wide range. And so I think this conversation is really exploring many topics and having you be able to share your expertise and know-how with listeners, and hopefully touching on some areas that I haven't explored before on the podcast. And just to start with, do you want to give listeners a bit of background on yourself? So who you are, what you do, what training you've done, that kind of thing?
Sure. I'm a psychologist with a group practice in Los Angeles where we specialize in eating disorders. And I'm also licensed in New York and Indiana. And I have about 7 employees. And I started my eating disorder training when I was in grad school at Rutgers, and I had the opportunity to train under Terry Wilson, who was one of the co-creators of CBT for bulimia before it was CBTE. He was Fairburn's main collaborator. So I got really good training back in the 1990s in CBT. And that was really when I fell in love with eating disorder work. And after grad school, I did a number of different things before I got back into eating disorders. And I actually got back into eating disorders when I was living and working in Shanghai, China. And I was there for my husband's job. And when I said I had eating disorder experience in the expat counseling community, I immediately started to be referred patients with eating disorders. And most of my training had been with adults with bulimia. And here I was getting adolescents with anorexia. So wow. I very quickly had to seek more training. And I actually flew to Stanford to do an FBT training with the official training institute. And after that, I fell in love with FBT and started to really learn and study FBT and treat adolescents using that model. And shortly after that, I moved back to Los Angeles and set up my group practice and got certified in FBT and wrote a book for parents based on FBT and got also very involved in health at every size as a philosophy.
Yeah.
And so I've really done a lot of training and self-development in that area. And then I guess my most recent interest is ARFID, because I had a behavioral background and had known Jenny Thomas. She really encouraged me to start seeing ARFID patients, and I did a lot of training with her. And so now the ARFID area of my practice has also grown. So I see children and adults with all eating disorders, all genders, and the 3 main things I do are kind of CBT infused with health at every size for adults, FBT for adolescents, and CBTAR for adolescents and adults with ARFID.
Nice. Okay. Well, I want to go back through each of those in detail. And for listeners, if you're like, I don't know what CBT or FBT or ARFID stands for, we will go through each of those. But just in terms of getting more background on you, like what was food like growing up in your household? How was food when you were a kid?
Food in my house was normal until I hit puberty. And then the adults in my life kind of panicked about my weight, and I started to be encouraged to diet. And I went through a lot of dieting from about 13 to 18 while everyone was worried about my weight. So that was a difficult time.
And were you doing that dieting on your own? Were you doing it with friends? Were you doing it with your
originally, I think I did it with my mother, and then after that, I was sent to people to fix my weight. Yeah.
And when you say sent to people, what was being recommended at that point?
Oh, restriction. I was sent to Diet Center, which was an old diet company that, it was a very sad food. I remember in high school going out with my friends and they would buy pizza and I would have my little chicken breast. So it was very depriving. I think I did that. I did Weight Watchers. I was sent to an individual nutritionist, sent to the gym. Yeah, everyone in my family was very focused on my weight and wanted me to be thinner.
And so what did you do to come out the other side of that? So you said that was up until a certain age. So how did that change for you?
I was in therapy in college, and that really helped me to break the diet cycle and to stop restricting. And that really helped. I was lucky and privileged to be able to access therapy, and that helped me to get past the dieting, and I never went back.
Wow. Okay. That's quite a big change. And what was the advice, or what was the thing that started to really make that change for you? I know you said you were in therapy, but what was the model that they were using, or what was the thing that made the difference?
I remember the most important thing at the time was the advice that I should have a sandwich for lunch and not a salad, which was what I had been taught in my family. And that the permission for starches seemed to break this, dieting, and then, rebound eating from depriving myself and then having unplanned eating later in the day.
And do you remember that? Was that a difficult transition, or is like as soon as someone gave me that permission, it just, I don't know, it locked in and I felt I could do this?
Yeah, I remember it being kind of like wow, it was that easy. So yeah. I mean, I didn't have an eating disorder, clearly. So I had some, disordered eating, but yeah, it was pretty quickly righted by just eating more regularly.
Did that then come as a bit of a surprise later on when you did start working with eating disorders, in terms of reflecting on your own experience, thinking, oh, I thought this was going to be more straightforward? Like I got that information pretty easily and was able to course correct.
I don't remember even when I first learned CBT, tying it so much to my own experience at first. I remember just seeing with the patients I was helping that a similar thing happened, that when we broke the dieting, the binge eating stopped, in many cases pretty quickly. So I think I was really drawn to the cognitive behavioral therapy model. At some point I must have related to it as well. I don't remember that.
Okay, fine. And so when you went off to study as a psychologist, what did you think you would be working in? Like what was the pull, or what was the interest for you with psychology?
I don't remember what I originally thought I was going to do, but I was in the psychodynamic track at my school and was very into that treatment. And then I had a friend who was a little ahead of me who was working with Terry Wilson and had really found it amazing training. And so I actually had to, because I was in the PsyD program, I actually had to beg him to let me train with him. And eventually he did. And that training just really swayed me in so many ways that I never thought I would like doing cognitive behavioral therapy. And I really just found it so effective. And I don't even know if I decided that was what I wanted to do at that point. I just wanted to train with him.
What was it about him that was so alluring, or just made you think I need to be here?
Well, I think in retrospect, it was the only really clinical research going on, in the grad program. I mean, there was some other things that just had no interest to me. And this was very clinical research. So I think that's what drew me to it, that he was, doing clinical trials of treatments. So it just felt very practical to me.
And did you feel like you might become a researcher and that would be your full-time thing? Or is it always the feeling of, I actually like doing the patient work and I want to be more working as a clinical psychologist?
Yeah, it was more around the clinical work.
Yeah.
Yeah.
And so, I mean, you mentioned there about you were on the psychoanalytic track and then you changed over. So for people who don't understand or don't know the difference between those two, how would you conceptualize what psychoanalytic way of therapy is versus the cognitive behavioral therapy way of therapy?
Yeah, so psychoanalytic or psychodynamic therapy focuses on there being some kind of underlying conflict that needs to be solved. And it's using the therapeutic relationship to kind of uncover what has gone on in someone's past in relationships and, to kind of looking in someone's history to solve the problems in the present. And cognitive behavioral therapy is more focused in the here and now, and it focuses on looking at current behaviors and thoughts and looking and analyzing those and making changes in the present to change thoughts and behaviors and feelings. So it's much more focused on what's maintaining a problem than what initially caused it.
And for you then, like now as a practitioner, is it purely CBT, or do you see some benefit in starting to explore, okay, what someone's history is and those kind of factors? I mean, even if it's not about helping with therapy, but just more about relationship building, like do you go back through those kind of things?
Yeah, I think in practice, everyone is a little bit eclectic. I think my primary approach is cognitive behavioral therapy because, again, the impact of working with Terry Wilson made a big impact on my way of thinking, in that, the research in support of behavioral treatments for eating disorders, shows that they're so important in interrupting, especially, dangerous behaviors in the case of bulimia. So I always kind of start with cognitive behavioral therapy, but it doesn't mean that my psychodynamic training doesn't inform me in some way and that I don't appreciate that people have a history and have been impacted by relationships in their past. And sometimes I will step back and think about people in more psychodynamic terms, but the work is still primarily cognitive behavioral.
Yeah. Yeah. And I would agree with a lot of the work that I do is in a similar vein, where it's either CBT or acceptance and commitment therapy or ways of like, hey, let's look at the current situation and how to make changes moving forward. But I also, I do think it's helpful to explore what it was like when you were growing up, or what was the impact like in terms of your mother's dieting or whatever, just so someone can have a better understanding of who they are and how they came to be, even if it, as you said, it doesn't necessarily change the present and the thing that someone has to do. And so I think it would be useful because, as I said at the start, I haven't really explored cognitive behavioral therapy or CBT on the podcast in really any detail. So I think it would be useful to spend a bit of time having a conversation around it. So what would be the best way of trying to do this? Like, would it be useful to maybe demonstrate CBT and how like a CBT intervention could work? Have we picked a particular thing like a fear of a particular food or a fear of weight gain or something like that, just to give someone a sense of, okay, what does CBT look like when it's being used?
Well, I think we should start with looking at the cognitive model.
Okay.
And so the key point of CBT is that it looks at the dieting or restriction as causing binge eating.
Yep.
And then there may or may not be compensatory behaviors other than restriction. So it's a cycle, and we start by drawing it out for patients and looking at, how dieting maintains binge eating. And most people come to therapy and blame themselves and say, I have no willpower, I can't maintain my diet. So the kind of key part of cognitive behavioral therapy is educating people on this model and helping them to see that it's not that they have poor willpower, but that their bodies are working perfectly, because our bodies were not meant to be deprived of food, which is one of our 5 basic needs. And so that's kind of the core element, I think. And one of the reasons why I think cognitive behavioral therapy fits in so nicely with health at every size and intuitive eating, because it really focuses on making sure that people are eating enough.
Yeah.
That doesn't mean that there isn't weight stigma in the original CBT manual, which is another pet project of mine. I've been looking at trying to address some of the weight bias in CBT. And I think some people want to throw CBT out because there is some weight stigma embedded in the treatment manuals. But I think at its core, the cognitive behavioral therapy that's just looking at thoughts, behaviors, and feelings that are maintaining a problem is weight neutral. And the way it's been applied in some cases to bulimia and binge eating, its weight stigma has entered. And it doesn't have to be there, because at its core, it's this model of making sure that people are eating enough.
Yeah.
And I think one of the things that people misunderstand about cognitive behavioral therapy, at least as I've seen other clinicians apply it, is they think it's mostly a cognitive model and that we're arguing people out of their food rules. And I think that's one of the misunderstandings of cognitive behavioral therapy. It's really primarily a behavioral treatment. And it's mostly about changing behaviors and changing thoughts by changing behaviors. So rather than disputing, whether it's bad to eat hamburgers, it's more about getting the person to eat a hamburger and then seeing what happens.
Yeah. And just in terms of your original statement of getting someone to understand that it's the restriction that's leading to this. I mean, even if someone doesn't accept CBT, I mean, you're just describing pure biology of like, this is what happens when you underfeed a human being. And This is what happens when you overexercise a human being. Like, there is energy that needs to be used for the body to function properly. And when that is restricted, there is a chain of events that happen, and we have it well documented that this is what happens. And so, I think it's really helpful to put someone in touch with the reality of the situation of like, this is pure biology that is driving you in this way. It's not because, as you say, about willpower or you being broke or anything. It's like, this is your body doing what it should be doing.
Exactly.
And I also agree with you in that second point about the cognitive, the word cognitive and getting in the way of people thinking about what it really is. And as I said before, I really quite like acceptance and commitment therapy. And from my understanding, that's somewhat of an offshoot of CBT. Am I correct in that?
Mm-hmm.
Yeah. And a big part of that is, the action taking. Like, it's not just how do we work everything out in theory. It's about the taking action and about the fact that by taking action, that's how you prove yourself wrong or discover that you could do that thing that you didn't think you would be able to do. I often have this conversation with clients, like, confidence turns up after the event, not before it.
Yeah.
It turns up.
I the same thing. I say you can't be, if you're afraid of doing something and you're waiting to not be afraid of it to do it, that's never going to happen.
Yeah, exactly. It's by saying, hey, this feels uncomfortable, I feel unsure, and then you do it and realize that you could do it, and then you do that a number of times, and with enough practice, it then becomes normal and it becomes okay. Or you see that it is still difficult, but I'm able to do it.
Exactly.
Yeah. And so, okay, and with all of that as a primer, would it still be worth going through a particular issue and showing how CBT would work?
Yeah. So one of the other things that's kind of a core element of CBT is keeping records, and whether someone has depression or an eating disorder, we usually ask people to keep track of something. So if someone's depressed, we might have them track their mood and their activities, because then we're using that information to help them make behavioral changes. So with eating disorders, we ask people to track their food intake. And this is not in a diety way. So and it's not meant to help people restrict or count calories, but it's for the purposes of really making sure that they're eating enough. And one of the things when we have breakthrough binges, after someone has instituted some regular eating, let's say there's a binge in the afternoon, and then we might work with them and kind of trace back and say, okay, what did you eat earlier in that day? Did you have breakfast? Did you have lunch? Did you have your snack? And looking for, were there times where they maybe missed a meal or snack, or they restricted, or they didn't eat enough, or maybe they went to, instead of having their snack, they went to the supermarket and bought a bunch of food, and then they came home and they left the food out, and then they reached for it and started eating. And then, so we can do these behavior chains where we look back and then say, okay, so if this situation were to happen again, is there something you could have done differently? Yep. And looking at, okay, maybe could you have had a snack before you went to the supermarket? And maybe you could have put the groceries away when you got home. So looking at just making behavioral changes to problem solve for future situations. So it's about learning skills and thinking through situations and then problem solving based on where people struggle and helping them to have skills to solve similar situations in the future. So I always think of it as developing a toolbox of skills. And as I work with patients and they say, oh, I've got this thing coming up, and I say, okay, well, what strategies are you going to use? Yeah. So they try to anticipate, okay, I'm going to the beach and I'm going to be in a bathing suit and I'm going to be navigating, how to eat in front of my friends. And so then we plan ahead and we say, based on what we've learned, what skills can you use in that situation? And they know, when they go into different situations, they have to have a plan for it. And all along, they're developing skills to handle different situations around food, around body, or, and around tolerating anxiety and distress.
Nice. Yeah. And a lot of what you talk about there is stuff that I do with clients as well. So I will get clients, I used to call it a food log. I now call it an awareness log. Mm. And yeah, it's okay, what time did you go to bed? What time did you wake up? What time are you having your meals? What are you having as part of those meals? What symptoms are you noticing throughout the day? What's your mood like throughout the day? And the thing I always say is I genuinely don't care what you eat in terms of a judgment side of things. It's more let's look at this objectively, and whatever's working for you, keep doing those things, and whatever's not working for you, let's figure out a way of doing something different. And yeah, starting to look through that and notice patterns in terms of, okay, I notice that every time on the days that I was doing this thing in the morning, in the afternoon, there would be this other thing that would happen. Or the days that I don't sleep very well, or the days that I had this thing for dinner, or whatever it may be. But yeah, just using that as a way for them to be objective with it and to start noticing some things. I often will use the rubric of, imagine this was the log that your friends had sent to you, and they're suffering with a thing that's similar to what you're going through. What advice would you give for your friend? Because I think sometimes it's a lot easier to solve other people's problems, and it's a lot easier to be objective and say the things that you're noticing through that when looking at it through that lens.
Yep.
And the same if people are having binge episodes, of doing an awareness sheet after that.
Mm-hmm.
And looking at, okay, well, what's the chain of events that led up to this?
Yep.
And it's, yeah, as you say, it's like, oh, I missed my snack in the morning, or I've had 3 days where I've been really stressed and I haven't been eating enough. Like 99 times out of 100, it comes back to you haven't eaten enough food, and
Exactly.
that's how you've ended up in this place. Or you've eaten the regular amount of food that you're eating, but there's this additional stress, or there was this additional thing on top. And so again, we're back in the realm of you haven't eaten enough food for what your body needs at this point.
Yep. That's what I spend most of my time telling people, is that they're not eating enough.
Yeah.
Yeah. And then, the logs really allow them to see it. And I think it's such a vital tool. And then you can really fine tune, and you find someone they want to work out in the morning and they can't figure out like when to do breakfast. And then you can kind of run experiments like, okay, well, what if you have like a snack before your workout and breakfast after? How does that work for you? And they can try it out and report back. And that's the other key element of CBT, is this idea of running behavioral experiments. And so again, it's more behavioral challenges than actually cognitive disputation. And so the person will say like, oh, I can't do this. I'm afraid to have a sandwich for lunch, right? And then you say, okay, well, how about if you run an experiment and one day you have a sandwich for lunch and one day you have your usual, and let's see how it goes. And then we look at the food logs together, and they say, oh, on the day I had the sandwich for lunch, I didn't have urges to binge in the afternoon or something. And so then you're able to draw it back to their own experience and say, not just like in theory, people do better when they eat more starches earlier in the day, but they actually see in my own experience, when I had a sandwich, I felt much better or something.
Yeah, definitely. And I think that's, for me, is so much of the work that I'm doing with clients is like, how do we get you back into your body? How do we get you back to trusting your body and noticing the feedback it's giving you, and being able to accept the feedback it's giving you? And so, yeah, using the logs can be a way of helping as part of that process. And the other thing is, like, I always said to clients, like, I'm not wedded to this. There will be times where actually for a client, keeping a log is worse for them. Like for whatever reason, it just doesn't work. Mm-hmm. And I don't want to then be getting someone to do something that feels like it's causing more harm than creating a solution. So it's like, okay, let's step back from that. Or maybe we can keep a log in terms of your sleep or your mood, but we don't put the food in, because at this point, that's just genuinely not working for you. And maybe we come back to it, maybe we don't. But I definitely feel like over the years of doing this work, I've definitely become a lot more open-minded in terms of some things work for some people and some things don't. And it's like, what is the best solution for this person that I have in front of me? Because the best solution is the thing that actually someone follows through on, or something that gets them to a better place, not some, in theory, this is the best thing and why aren't you just able to do it? Right.
In that situation, I also, one of the things, are you familiar with Appetite Awareness by Craighead?
No.
So that's actually I think an ACT and DBT based model that also has some weight bias in it, but they have this sheet that's meant to be an alternative for people who will not do food records. People who just keep their appetite, their hunger and fullness ratings for each meal. And they literally just put X's, and there are these nice sheets that, like, intuitive eating does 1 to 10. This one is actually 1 to 7, which I like because it feels more symmetrical to me to have a single number in the middle. But so sometimes I will have patients do that, just literally, each time they eat, put how hungry they are when they start, how full they are when they stop, and they don't have to put the contents of the food. And sometimes that's more tolerable for people who don't want to write down their food.
I did. So I didn't know that was what it was called. So I use hunger and fullness from intuitive eating with clients. And sometimes that is when they're writing down the food. And then sometimes that is as an alternative.
Yeah.
So yeah, that's something I use. Also getting them to put down a satisfaction score as well, because I think that's also a really helpful thing to explore, where it's like, it's not just about getting full, it's about the enjoyment that you got from that meal, the different tastes and texture sensations that make up that meal. And that could be getting more into the advanced end of things further on down the line. But yeah, getting someone to start to notice those differences again, because it brings you back into your body. It gets you back to listening to your body and understanding the feedback it's giving you.
Yeah. I haven't used satisfaction ratings, but another little tip I just learned from Nancy Zucker, who I'm doing her training in FBI ARFID, which is ARFID for little kids. She actually teaches kids to measure their energy rather than hunger and fullness. And I actually thought this was like an amazing reframe for some patients who may not be aware of hunger cues so much, but they may be able to notice their energy and fueling. So I've started to think about incorporating that a little bit, even with adults.
That's cool. So when I'm working with someone, I have a whole list of hunger symptoms that I send over so that they understand that hunger isn't just a growling stomach or a pit in your stomach, and that can be everything through to from like, I'm feeling a little bit tired, I'm getting more irritable, I'm getting a headache, foggy head, I'm noticing the tips of my fingers are a little bit cold, or my nose is a bit cold. So that there's this big long list that people can look at, so that even in the beginning, if they're saying, hey, I don't feel hungry, they then look at the list and think, I've actually got 4 things on this list. It probably does start to indicate that I am feeling hunger. Because if I'm thinking about myself, I've gone way, way, way past the point of hunger before my stomach is growling.
Right.
So if I'm using the more obvious classic forms of hunger, I'm delaying my eating way, way past the point of where it should be.
Yeah. And I like the idea of reframing fullness as having a full energy meter, I think. Because fullness is so often pathologized, and the positive reframe of being appropriately fueled may be easier for people to recognize. Yeah.
And I was part of that as well. Look at what is the longevity of the meal that you just ate? So how long does it take you before you are feeling hungry again, or your energy is getting low again, or you're starting to have food thoughts again? And so you're like, oh, great, you found a meal that's now taking you for 2 hours. Before you were only able to do 1 hour. And so, again, using it as a positive reframe, because most clients who come to me are like, I want to stop the food thoughts. And so if I can demonstrate a way that means that you're having less and less time of the day thinking about it, that's a positive or a thing that they are wanting to get on board with.
Yep.
And one of the things you said earlier that I wanted to just come back to, because I think it's important, was you talked about, okay, if we're going to the beach and I have to eat, like what would be some of the things that I can do around this, and the planning of those different things. And part of the planning piece when I'm working with clients is explaining that I expect this to be anxiety provoking, or expect you to feel uncomfortable here, and to kind of set that up so that people don't go into it thinking, if I'm doing everything right, I would feel fine here. Like making like this contact with the reality of like, this is what is likely to happen, and that is completely okay. And that also means that you can put on the swimsuit or eat that meal with your friends or whatever the thing may be, but not having someone think that I will do those things when I don't have these uncomfortable feelings. And that's my indicator that I'm at the right place to start doing this. Right.
Yeah, that's, I think, one of the hardest things to explain to people with fears is, they want to bargain that when they're no longer afraid of it, they'll do it. And the really hard thing is that the only way to not be afraid of something is to do it first. So that's why exposure is so hard, but it works so well.
Yeah. I think one of the ways that I've worked on this with clients is to try and move it out of the realm of food. So to say, okay, what are some other things that you've done in your life that have been challenging, that were anxiety provoking, but you were able to do? And it could be the classic like public speaking or something along those lines. And someone could say, okay, yeah, I realized that there was this other part of my life where I did that, where I did it a number of times and I was able to get over it or get better with it. Because I think when you're in an eating disorder, the food side of things can seem so much more monumental, and it can start to get in the way of realizing like, oh, I've done this in other realms.
Right. Yeah. And building, it's all about, so it's not just exposure, but it's also building someone's belief that they can handle it. So,
yeah. And I also with acceptance and commitment therapy, and I don't know if this is the same with CBT, but when they talk about exposure therapy, I think there's this idea that in kind of classic exposure therapy, it was, okay, as we keep exposing you to this thing, your level of anxiety will neatly come down from a 10 to a 5 to a 3 or whatever. And the goal being that you get to a place where you feel completely comfortable doing that thing. And I think what they talk about with ACT is more what you're meant to be doing, as opposed to having that come down, is just learning that despite the uncomfortableness, you can still do that. And exactly. If there is a side benefit of it starts to come down, and that typically does happen, great, but that shouldn't be the end goal.
Yeah, that's what the new research about exposure therapy seems to be showing, that exactly what you're saying. You've said it very nicely.
So you've written a book called When Your Teen Has an Eating Disorder, Practical Strategies to Help Your Teen Recover from Anorexia, Bulimia, and Binge Eating. Obviously, you're well-versed in this area. Like, what percentage at this stage of your practice is children or teens?
Probably, I'd say 50% of my practice is teens at this point. The demand for FBT has exploded in the last year with the pandemic. And, it's interesting, when I wrote the book in 2018, I was kind of like, okay, now I'm going to be getting tons of FBT patients, and they didn't come. And I really waited, and I thought, and it was slow for a long time. And then in the last year, now it's really, the demand for FBT has finally arrived, and I'm quickly trying to train my staff to be up and running to offer FBT also, because I can't see everybody myself. So I'm doing a lot of FBT right now. And okay. Should we describe what FBT is?
Yeah, I was going to say that would be the thing. So, like, what is the acronym FBT stand for, and also, give us an understanding of what it is.
So FBT stands for family-based treatment. It's sometimes referred to as Maudsley family therapy, and that just reflects the fact that it was originally developed at the Maudsley Hospital in the UK. And it's a treatment that was manualized by Jim Locke and Daniel LaGrange. And it's a short-term, also primarily behavioral treatment that centralizes the role of parents in supporting their teens' recovery. And it's used primarily for anorexia, but also for bulimia. And it's kind of like parents... Well, it's an example of task shifting, right? So task shifting is a model of therapy where you're training less trained people to actually administer the treatment. And in this case, the parents are enlisted to do the role of what would often be done by the staff at a treatment center. So parents are empowered to plan, prepare, serve, and supervise all the meals throughout the day. And in the case of bulimia, or when there's excessive exercise, they would be supervising outside of meals as well to prevent behaviors like purging and exercise. And so it's a treatment that is very different than traditional treatments, right? Because traditionally parents were often seen as part of the problem of their teen's eating disorder, and teens were typically removed from the home and sent to treatment centers, and then they came back. And so this is really revolutionary in terms of what it's doing, and it allows teens to stay in the home and to try to get well with less disruption to their lives.
And with it, is there then still a team that is working with the teen? So they're then having a separate therapist and like there are other people, or it is really the family then plays all of those roles?
Well, there's a therapist or clinician guiding the parents and supporting them. And there's got to be a medical doctor to monitor the teen medically and in terms of vitals. But oftentimes and at least in research, that's the core team. So, you might pull in other people as needed, but really it's the parents who are on the ground in the house doing the meals, right?
Yeah. And I mean, you said originally after writing the book, there wasn't as much uptick as you may have thought, and now it's been busier. Does a pandemic create the kind of situation that favors doing FBT because everyone's in the house and they're not going out and kids are in the house, and so it in a sense makes more sense to be doing it in that manner?
Yeah, in many cases it was the ideal condition for FBT, right? Because no one wanted to travel. Parents didn't want to send their kids to residential, especially in the early days of the pandemic before, medical staff was vaccinated, right? It was terrifying. And, I remember families that were really torn about whether to send kids to residential at that point, when in other situations, they probably would have just sent them, especially when it meant flying and going to different states. So, and then, before the pandemic, I remember the struggles of trying to figure out how you were going to get in those meals, and parents would typically go to school. The child would come into the car, eat lunch in the car, and go back in. And I remember emphasizing that this needed to be done. And then, during the pandemic, we had this situation where parents and kids were all home. So it really did make the meals supervision easier for many.
Yeah. And with this model, I guess you're then going to have the parents really being on board with this. And I imagine also having to eat a lot of meals alongside the children. So given everyone's favorite pastime of dieting and having issues around food, like how much of this is an education for you to the parents? How much of a pushback is there for parents thinking, gosh, I don't know if I can do this?
Parents can be educated pretty quickly when they realize how sick their child is. They very quickly get on board with the idea that they need to eat more, and most parents very quickly acknowledge any dieting that they were doing, and many will gain weight right there with their teen. I think that a crisis like that is a great opportunity for learning and re-education in the family.
Yeah. Yeah. How widely accepted is FBT?
It's hard to say. I think it's becoming more widely accepted. Like, the word seems to be out now. It used to be, because it's evidence-based, it's well-researched, and it should be kind of the first line that's offered to a teen, who presents with an eating disorder, because it's an active treatment like CBT is, right? It's actively changing the behaviors. It's just doing it through the parents kind of requiring the behavior changes, because we assume that, many teens with anorexia are not on board with making behavioral changes. So it's empowering the parents to kind of require these changes. So I really see it as parallel with CBT in many ways. The research on FBT shows that it's most effective when applied within the first 2 years, and it really should be the first line. And it's still sad to me when I see so many families who've just tried individual therapy for like a year. And then they decide that's not working and they come to me, and I've got a couple of families where there's been no weight gain in a year, and teen has been malnourished that long. And it's pretty upsetting because in family-based treatment, we want to see 4 pounds of weight gain in 4 weeks to know that it's going to work. And if we don't see that, then we're trying to push for a higher level of care typically. So it should be something that people try first. It still doesn't seem like it's the automatic go-to.
Yeah.
I think it's gaining in recognition, and people are hearing about it sooner. But I still don't think that it's like as and then of course there's not enough providers, right? So even if parents do learn about it, every FBT provider right now has a waiting list. So, but hopefully this increased demand will result in more people getting training in it.
Yeah. Well, also I would say another barrier could be just parents' availability. Like if you're saying someone has to go and meet a child at a school gate to feed them lunch, and for a lot of parents, they with a regular job, they may be unable to do that. And so for them, doing inpatient is the alternative that appeals because there is no other way.
Yeah. And I think also, I just think sometimes residential treatment is seen as the gold standard, like that's the best. And so I think parents are kind of lured into that sometimes by glossy advertising. And maybe they think that FBT is lesser than because they're doing it themselves, but it's actually more evidence-based. But there are many ways to do it. So, I think that's, to me, one of the more interesting aspects of it is the creative solutions that each family comes up with looks different. So there are, and I've done FBT with many low-income families because I accept a type of Medi-Cal, which is a county-funded insurance for low-income families in Los Angeles. And there are many situations where the school finds someone to supervise the lunch, whether it's the school nurse or the counselor or favorite teacher. And I've had grandparents fly in from other countries to come help out. So it's not, I just want to make it clear that it's not just for those with the most means, but there are creative ways of involving people and getting the supervision done.
Yeah. And look, I am all for it. And I think you said there is the glossiness of inpatient, and I worked with many people who have done inpatient and it just really has not worked. Like I think for inpatient to work, you need to get lucky and get to the right place and have a place that does things in the right way. Otherwise, it can really be a disaster. And I know a lot of people who've been set back in their recovery because of going to inpatient facilities. So while it's often sort of sold as the gold standard, I don't think that is always the case.
Yeah, and especially for teens, especially these younger 11 and 12-year-olds, but I've done FBT through the 20s. So I think the misconception is that it doesn't work for older people, but especially when you think about sending 11 and 12-year-olds to residential treatment centers and some of the things that they're going to be exposed to there, it's really, if we can do it in the home, I think it's so much better.
Yeah. And also, the thing with inpatient is at some point you're going to have to return to the home. Exactly. And you're going to have to learn to do that anyway. And often with the way that the insurance is, you're returning out of the inpatient facility, not at a place of anywhere near full recovery. You've gained some weight, you've done some of the important early bits, but you're still a long ways off. And so you then need to start doing that in the home anyway. And so, yeah, I think you're right. You can just start from that place to begin with. I think for me, where I first heard about FBT was through Gwyneth Owen and her website that used to be called Your Utopia about 10 years ago. And I think she was talking about it for kids, but then talking about it in a sense of like, for adults, this is how you need to do it for yourself.
Yeah.
And so what about for kids or even teens? Are there signs or symptoms or early warning signs that you think people should be looking out for in terms of eating disorders, or maybe not even an eating disorder, but just changes that could be occurring that could be the precursor to an eating disorder?
Yeah, important point. So parents will often describe very subtle changes in the early parts, like the teen gave up desserts or stopped coming for snacks. And parents usually think, oh, well, like they're stressed or they're busy studying. And another common early sign is kind of more exercising and increasing their commitment to exercise. And these changes are subtle at first, and then they usually kind of escalate. So then they're not coming for breakfast or walking a couple hours a day. And because those are behaviors that often look good at first, right? Like parents are like, oh, they want to eat healthier. That's a good thing. Or, oh, like exercise is good for their mood, right? And so there are these innocuous behaviors at first. And that's, I think, one of the reasons why eating disorders kind of really sneak in.
Yeah.
Yeah. And, later on, it usually becomes clearer that there's weight loss or mood is really difficult or, things are really tense at meal times. Another common but often missed behavior is like obsessions with cooking and cooking for other people, but not eating it, or watching a lot of cooking shows. So those are some things that the parents can watch for.
And I guess the one in terms of, well, not necessarily weight loss, but even just slowing of weight and height and all that can sometimes be difficult to spot if it's in a teen and they're now at the point where they're going through their growth spurt, but you're not now seeing it because of the restriction. And so right. You're like, oh, well, maybe they just haven't hit that point yet, when in fact they should be square in the middle of it, but you're just not seeing it because of the restriction.
Yeah. Yeah. It makes it so hard.
Yeah. I mean, one of the other things, I haven't looked into the research around this, but it's something I've identified through clients I've worked with, is that for many of them, they remember when they were teens or before the eating disorder started and talk about the fact that they used to eat a lot of food and they just were naturally, spontaneously consumed more food than the average person. And in the beginning, that was something that was completely fine. They didn't think of it as a bad thing, or they may have even thought of it as a positive in terms of they're able to out-eat their brother or whatever it may be. But at some point that changes and it's been then seen as a negative. But it feels like for a lot of people who suffer with eating disorders, their natural propensity is they just need more food than the average person. And when that starts getting restricted, that's when the switch gets turned on and they fall into the eating disorder. Mm-hmm.
Yeah, I've had a lot of teens claim that they were binge eating before they started restricting, and I think it's just they were probably eating normally.
Yeah.
And then, they pathologize it looking back. But yeah, they it can be a subtle shift, right, from eating what may have seemed like a lot to just less than that.
Yeah. And you made a comment before about when doing FBT that you want to see someone put on, was it 4 pounds in the first 4 weeks or whatever the amount is. So as part of it, are you using weighing of clients and are you setting goal weights? Is that how it works?
Yeah. So with anorexia, or when someone is clearly weight suppressed, that's the immediate target. And so that's another area where FBT is like CBT, where we're prioritizing the immediate, solving the problem as quickly as possible. So stopping restriction and getting weight on when someone's restricted. And so the research indicates that 4 pounds of weight gain in 4 weeks is prognostically significant, meaning that it's very tied to whether the treatment is successful. So that's not an arbitrary thing. That's based on what the research shows. So if you don't see the early weight gain, then the treatment's not likely to work. So you don't want to waste a lot of time. You don't want to keep a teen malnourished for 3 months with a treatment that's not working.
Yeah. Do you do the same with your adult clients?
So tricky. Well, I find that it's very, very hard to have an adult gain weight on their own in individual outpatient therapy. So I very rarely accept adults with anorexia unless they have meal support, because I very rarely had adults who were able to really weight restore with just individual psychotherapy and individual, outpatient dietary support. So usually when I see adults, it's more for bulimia or binge eating, or I'm doing FBT with young adults.
Okay. That's interesting to hear. So I do work with people who suffer with anorexia and are able to help them put on weight. And the reason I was asking around, do you weigh clients, is I don't get clients. I mean, if clients want to, and we can see that there is some benefit in them doing it, we will, but most of the time I don't need to. We can start to see things are going in the right direction by looking at their symptoms, by looking at their food log, by looking at so many other factors that I don't think that the weighing for most people is helpful. I also have had clients as well who have been given goal weights, and where that then becomes a real problem because they're now knocking up against the weight that they were told was going to be the upper limit of their goal weight, and now they're still not recovered. And so for me, I'm always like, when I have my initial chat with someone to work out, okay, are we going to work together? I'm always really blunt around the fact of like, I don't know where your weight is going to go, and I don't know where it's going to end up. And I don't want to make any promises around that because I'm not in control of that. Your body's in control of what it wants to do as part of healing. And so there's a part of me that's like, I can understand in certain circumstances why A, weighing people can be helpful, and B, where setting some kind of a weight goal, but I see a lot of it causing problems. And goal weights being set ridiculously low that guarantees someone is going to continue on with an eating disorder or disordered eating afterwards, because there is no amount of recovery that is going to take place by the time they've got to that goal weight. Yeah,
I think that's such a challenge. I've tried many different things with, no goal weights, giving a range, giving a single minimum number. I think any way you do it, there's potential trouble.
Yeah. And
with adolescents with anorexia, I definitely weigh them more now that we're doing the home version. The parents or, somebody, the pediatrician weighs them and sends me the weights, because there would be no way to know with the teen over video whether they're gaining weight.
Yeah.
And probably even in the office, it would be hard to gauge, because so many become hypermetabolic that the parents could be feeding them 4,000 calories a day and they're still not gaining weight. So I couldn't just rely on the fact that they're eating that much and to be sure. So I think you do have to weigh in that circumstance. And I tend to use growth curves to predict where we think a teen will get healthy.
Yeah.
And of course you can couch it in all the ways that, this is just a predictor, but they hear the number. And I feel like I feel like it's helpful to give parents a number, because sometimes the parents come to me and the teens only lost 5 pounds, but meantime, like they should have gained 20, during that time that they've been ill. So then I need to say, like, no, this teen has to gain 25 pounds to get back to their growth curve. And the parents are thinking they only have to gain 5 pounds. Or I think it helps parents know that, like, this teen has to gain at least 10 pounds. This teen, has 40 pounds, because they know how long it's going to take. When you say it's going to be 1 to 2 pounds per week, are we going to be doing this for 5 weeks or 20 weeks? And also to emphasize the the need to go faster, because you've got a teen who's got to gain 25 pounds and you're gaining half a pound a week. It's going to take a year.
Yeah.
Which is not really a good thing for a teen who's not menstruating. So I do find it helpful to give a target range. But then again, when you give a range, then they hear the top number is a number at which they should never go over. And so then that becomes pathologizing. You give a single number, and then they're like, they want to just stay just beneath it. So there's kind of no good way. I'm struggling with that.
Yeah. Yeah. And I guess the difference as well with you and the teens versus the clients I'm working with, I'm very upfront in terms of the services that I'm able to provide, and that we're having these conversations and we're talking every 2 weeks. They've got email support. We're doing it in this manner. And it's like, if you need a higher level of care, then we are not the right fit. Mm-hmm. Whereas if someone's saying, yes, I want to do this, there is already that motivation there. They're already saying, cool, I want to take these steps. Even if there's still a lot of the eating disorder saying, no, you shouldn't be doing this. If someone's signing up to work with me, it's very different to a teen who is going through the FBT, who is doing it through gritted teeth because their parents are making them do it. And
right.
If they are left to their own devices, they're going to continue full-blown into the disordered behaviors. So I think having those two things being different means that there's different methods that are in place.
Right. Yeah, I rarely weigh adults anymore. And that's really come from my haze overlay over CBT.
Yeah.
Yeah.
And so one of the things you mentioned early on was about the ARFID. So that's Avoidant Restrictive Food Intake Disorder, if people are wondering what that acronym stands for. So yeah, it's something I haven't chatted about on the podcast before. So do you want to, again, talk about what this is?
Sure. So ARFID is a diagnosis that only came about in the 2013 Diagnostic and Statistical Manual. And before that, it was a disorder only recognized in younger children. It was in the feeding disorders of childhood category. So research on ARFID as the diagnosis that we know it now is pretty new. And ARFID is basically when someone has an eating disorder and they don't meet their nutritional needs, but it's not out of a fear of weight gain, as in anorexia. And they have complications from not eating enough that either affects them socially or medically or affects their growth. And so again, these are people who don't eat enough there. And there's three types of ARFID that have kind of been identified. One is sensory sensitivity type. And these are people who are very sensitive to different tastes and textures. They may be kind of super tasters, if you've heard of that. They're often born that way. So they may have other sensory sensitivities, like, they may be sensitive to like the tags in their clothing, and they may prefer certain textures over others when it comes to food. And because foods have very intense tastes to them, they tend to kind of stick to this narrow range of familiar foods. And anything then outside of this narrow range feels very foreign to them. So that kind of maintains this narrow range of foods. The second type is... Just with that first type, I mean, when the way you described it there, I could see that there could be overlap in terms of autism with this. I could see there also being overlap with some people who have high sensitivity, HSP. Yeah.
That be part of this.
Yeah, like sensory processing disorders. There's some overlap. Yeah, and autism. There's some overlap as well. So that's the first type. The second type is low interest type, and this may also start at birth. It may be people who are born with low hunger drive. And they're just not particularly interested in eating. Food is not that rewarding to them. You can kind of They just don't get very hungry. And these are people who have kind of always had a low appetite, always had trouble kind of keeping weight on. And it's just really an effort to eat enough for these people. And then the third type is fear of aversive consequences. And this is usually associated with an underlying anxiety disorder. And it usually has a more acute onset later in life. And it can be in response to a choking episode in themselves or others, or a stomach flu. And then the person develops a phobia around either fear of vomiting or fear of choking. Those are kind of the more typical ones. It could be fear of an allergic reaction to food. And this one is more like a phobia and can overlap with a phobia. So you can have a diagnosis of like emetophobia, vomiting phobia, and also have the diagnosis of ARFID. And again, the difference would be that then the person is not eating enough and it's affecting either their weight or their health or their social interactions. So, people who then become afraid of vomiting will develop all kinds of safety behaviors, like they won't eat to fullness, or they won't eat, spicy foods, or they won't eat in the evening, right? And people who are afraid of choking will often avoid foods that are more chewy, and they may start to restrict more and more till where they're only eating like a liquid diet. And of course, then there are often medical complications when people start to restrict so much. And then among the three types of ARFID, there's often people have more than one. So people can have multiple types of ARFID, and people can also have ARFID and anorexia, for example. So it gets complicated, and the treatments are a little different. And there's two main research groups in the US that I'm aware of that are exploring treatments for ARFID. And one is a group at Harvard led by Jenny Thomas and Cameron Eddy. And they have a treatment manual called CBT-AR, CBT for ARFID. And they've been collecting research on that treatment, and that's for ages 10 and up. And then the other group is led by Nancy Zucker at Duke, and her treatment is called FBI ARFID, and it's Food and Body Investigators ARFID Division. And it's this adorable treatment that she's developed for kids 5 through 9, where she makes them into FBI agents, and they've become investigators learning all about the body. And she tries to help them reframe sensations and feelings into something to be curious about rather than scared of. And she has these, little characters. She has all these little illustrations of these very cute characters like Henry Heartbeat, and I can't remember the names of the others, but to teach kids all about the functions of the body.
That's really cool. That's a really nice way. I mean, even with adults, so much of the work that I do is like, okay, let's bring curiosity to this. Let's have it be an experiment, like how to do so in a lighthearted way, or not a lighthearted way, but just take off the pressure of having to do everything right. And I guess it's the same here of like, okay, let's learn how to listen to our body and do it in a mindfulness way, where as opposed to I'm trying to get rid of this thing or I'm trying to get away from it, it's more like, okay, let's learn how to accept it and explore it and be curious about the sensations.
Exactly.
Nice. And so it sounds like ARFID is a lot more common where it's started out from a very young age, like in terms of the first two categories that you listed there, in terms of low appetite or in terms of the sensitivity to tastes and textures, etc. It's unlikely or less likely, or you maybe I'm wrong about this, you tell me, but someone developing that in their 20s or 30s or 40s, and yet they hadn't had that prior.
Yeah, for the first two types, it often exists from childhood, but many of these people never got treatment as kids. So I'm actually doing a support group for adults with ARFID now. These are people who've had this since childhood, and it wasn't a diagnosis then. And some of them, their parents either didn't recognize it or didn't know what to do, or several of them had doctors who just minimized it, and some were malnourished for years. with ARFID. So it's really, I think, just starting to get some, recognition and like we're really in the early stages of finding treatment for it. And I was on a call and Kendra Becker, who works in the Harvard group, was saying that they're discovering a whole slew of middle-aged onset of ARFID as well. Okay. Possibly related to, menopause changes and GI symptoms that's causing people to middle-aged, I think she said women, but to like not eat enough or to be afraid of eating. And so I think we're just really learning more about ARFID.
And I wonder in terms of the later in life part, if because of COVID, that starts happening. So I've got a client that I used to work with who got in contact to say, my taste is gone, my smell's gone, and this wasn't just a short-term thing that happened. It's gone on for months now. And so I wonder if after that starts to come back, or if it only comes back in small amounts, how that's going to affect people who have had that symptom as part of COVID.
Yeah, so interesting. Yeah, we may have post-COVID induced ARFID.
Yeah. And the bit about the fact that this has gone on for so many people since birth and for as long as they can remember, and you're then catching it in their 20s or 30s, that must be so difficult for some people to then get away from the fact that, oh, I'm just a picky eater, or like, this is just who I am. And I think for often it's a struggle with anorexia or more with anorexia in terms of that becomes someone's identity, and they really identify as being either the thin one or the fit one or whatever. And at least with that, you can start to touch into, okay, what was going on before your eating disorder? What were you interested in before then? And you can start to kind of separate those two things out. But if you've got someone who, for the first 30 years of their life, this is all they've ever known, is it difficult sometimes to get people to realize that this is a thing, and it is an important thing that they need to get over, and it's not just who they are?
Well, I think many of them are motivated to work on it once they identify it and know that there's some help. I think some have been, more resigned to kind of live as a picky eater. And even the Harvard group shows that for people who have been, the sensory sensitivity type, the picky eaters, they say we're not going to make them into foodies. Yeah. Like, you can get them to be, the goal is to get them to increase the range of foods and for health reasons to include more food groups, right? But they're not going to develop the biggest palate. So on the other hand, I have a couple of teens who really have developed amazingly big palates. So, I wonder, I'm sure with everything, there's a range, right, of how much people can expand. And some will probably always be fairly picky, but I think help for them can really just validate that, yes, you have this condition and it's a real thing. And you're not just like being stubborn or difficult. And it's okay if you mostly eat chicken nuggets. Because there's also a lot of shame in ARFID. And it's interesting because ARFID is often seen as, because it's not weight focused, right? That I think we often think that like diet culture doesn't play in as much. And I'm really seeing that diet culture does play in, because people are being shamed when they go out for always ordering like chicken strips and French fries, and, not eating salads.
Yeah.
Right. Or just the influence of other family members having like not given them one of the things that may have been like a good food for this person with ARFID, right? So there's just so many things to unpack with people who've had ARFID for a long time.
And so what is the way of dealing with it? And so I know you said CBT, ARFID. Is it similar to what we talked about before in terms of, okay, we're going to keep a food log or awareness log, we're going to set up challenges where we're doing exposure therapy? Is it that same kind of model?
It's actually a pretty different treatment. So let's start with the fear of aversive consequences. That is more a true exposure treatment, like with an exposure hierarchy where you make a list of their most feared situations and you go up the ladder exposing them. So, if a person who's afraid of choking is most afraid of steak, and they're only eating a liquid diet, right, then you would make a hierarchy of like starting with the easiest thing beyond liquids and working the way up to getting them to eat steak. And there might be other things like eating with people, right? Eating steak with someone versus eating steak alone, right? So you can have all these things on the hierarchy. Oh, and I should preface by saying you always start ARFID with making sure that someone is eating enough. So that's similar to CBT. And you want to make sure people are eating regularly because many people with ARFID have just like given up eating or gone to grazing. And then that really further dulls the hunger signals. So you want to put them on a schedule of regular eating regularly throughout the day. If they're malnourished, you also have to restore them to health as soon as possible. And you give them permission to do it on their preferred foods. So whatever that is. So if the, child is only eating French fries and pizza, fine. You want to, make all their meals foods that they'll eat.
Yeah. I always say to clients, like calories trumps everything else. Like, yeah. It's like, let's get in enough food, and yes, variety matters, and yes, challenging fear foods matter. But if you're not doing the calorie side of things, or you're not getting to a good place with that, then getting stuck in the weeds with the other stuff is it's just not the time to do it.
Yeah. Yeah. So, and then the fear of aversive consequences type, like I said, is mostly an exposure hierarchy, and you're doing this outside of meals, right? So they're still getting their nutrition, and then you're doing exposures just to eating whatever the fears are, or feared situations, right? Because people with fear of vomiting may fear being near children or, going to school or, so you can build other things into the exposure hierarchy.
Am I right in thinking that with emetophobia, so the fear of vomiting, that the last step with that is actually having someone be sick? Like, is that the last one? No,
you don't have to do that.
Okay, fine.
Are you relieved?
No, I've had some clients where this has been a thing for them, and I've kind of referred out with this part and said you can see someone about this if it's something that's having a real impact on you. And when I was doing some reading around it, I thought that was the last one, or maybe I'm misremembering that.
Yeah, no, I don't agree that you would have to do that. And most people say you don't have to. I think you just have to have people do all the things that they are avoiding.
Okay.
Right. So, it could be like eating and then going on a roller coaster, right? That could be the top of their hierarchy. So the sensory sensitivity type is actually, I think, really fun to treat. So basically the core part of this is you give them this huge long food list and you ask them what foods they want to learn about. And for each session, they choose 5 foods and they bring the foods as they want to try them. And you do this very non-pressured exploration of these foods according to the 5 steps. And you ask them to use non-judgmental language as they tell you what it looks like, what it feels like when they touch it with their hand, what it smells like. And then the last 2 after they taste it and chew it and swallow it. And the last 2 are what does it taste like and what does it feel like in their mouths. And you ask them to just try 2 bites of each of these foods and to answer those questions. And then the goal is to get them to do about 10 trials with each of these foods. So they have to practice during the week on the same foods, any of the ones that they tried that they're willing to keep trying. And you ask them to record the trials. And then after they get to 10 trials, then you ask them, okay, and is that a food that you are able to incorporate And if so, you talk to them about how they might incorporate it. Like if they tried apples for the first time, would they have a couple slices as part of their snack? Or they could choose they don't want to keep trying the food. And then you move on to 5 more foods. So it's slow at first because these foods are unfamiliar and takes about 10, it could take up to 15 trials before they'll accept it. And for people with ARFID, like it's, they're with this type of ARFID, they're often just afraid of trying anything new. So the anxiety can be really high, and you can start with really low level fruit. So with one of my teens, I had to start with Pop-Tarts as like a new and novel food that was, less threatening than other foods. So they get experience in all these different foods that they're trying, but they also then get experience just in the experience of trying something new. And so they get less scared. And over time, it's amazing to see that they'll start to become more confident in trying new foods. And most of the people I work with will report that like then they finally have courage to actually try something outside of our sessions. Like they'll be in an event and they'll actually like try something, and it's like shocking to the family. But it's slow because you might try 5 new foods each week, and then 2 weeks later you've kind of added 2 foods. So, and then the goal is to keep the newer foods in some kind of rotation, and you encourage them to keep incorporating them so that they don't kind of drop off again. Yeah. And you go back through maybe like foods that they used to eat that they may have dropped, or foods that are similar to other foods, or you try to also expand their flexibility. Like if they only like have a preferred brand, they'll only eat like one brand of chicken nuggets. You try to see if you can get them to try a different brand of chicken nuggets or from a different restaurant, and expanding that way. And during the pandemic, these were the families where like they were running around. The kid will only eat chicken fingers from this one restaurant, or like only eat this one brand of mac and cheese. And when food was short and things were crazy during the pandemic, like these were parents who were trying really hard just to nourish their children.
Yeah, that would be difficult. And I was thinking, as part of, you said, okay, it's a really slow process. And I mean, recovery is slow. Like when I think about my clients, like I think there can be this misconception around recovery from reading people's recovery stories online or whatever, that I should be done in 5 months, or I should, and for a lot of people it just takes a really long time. And so if it takes that amount of time, it takes that amount of time.
Yeah. And then the goal is you get them to the point where they can continue to try new foods on their own, because there's a whole world of foods. And I think in their research, they've done about 20 sessions, and then because they're also capitated. So but that seems to be about a good number. I've been counting, and 20 to 25 seems to get the people to a point where they can then continue to try foods on their own.
Well, I think by that stage, you have, as you said, you've done it enough so that you've got over the anxiety of trying new things. And I would also imagine that as time goes on, you're now, when you're tasting that food, you're able to say, okay, there's the sweetness that reminds me of that other food that I tasted, and there's this texture of this other food. And so it doesn't feel quite as new because you're able to recognize it as being a similarity, similar to these other things.
Yep. Yeah. And then you can also do like chaining, right? So someone who likes pasta and feta cheese, right? Then you try some recipe that has them together, right?
Yeah. And so what about then the middle option that you described? So someone just has a low appetite. That's
the hardest. And, with a kid, you can pretty much do straight FBT and get the parents to get them to increase their volume and get weight on. With adults, I've really struggled, and I've sought a lot of supervision from the Harvard group, and they say this is also where they struggle. This is with adults, a lot of very heightened sensitivity to internal bodily sensations that increase anxiety and make it harder to eat. And just they're looking into like medications, and there's a lot of overlap with GI issues. So I was encouraged to do a consult with someone who works in their GI clinic, and they were basically talking about medications that can help. So I think we don't have the best answers to that. I think it's about the treatment in CBT-AR. It's about trying to get them to push past fullness, to be able to tolerate more fullness, to better tolerate the bodily sensations that come with eating. And the patients I've worked with just describe how it's just so much effort to get themselves to eat enough. Some of them have worked really hard and gained a lot of weight, and they're still saying, like, does this get easier at a point? It requires a tremendous amount of focus. And interestingly, when I've given the assessment called the PARTY, which is the PICA, ARFID, I don't know. It's like this assessment that assesses ARFID. And the one question that all the people with ARFID seem to relate to is, I find eating to be a chore. Yeah. And I just think about that in terms of the low interest ARFID. It goes against their biology, right? For some reason, eating is not rewarding, and it's a chore, and it requires so much effort. And to have to really focus on it and eating enough is really, really challenging.
Yeah. I mean, that sounds really tough, because at least with all the other eating disorders, you're working with biology in a sense of like, okay, once you start to eat more food, you get hungrier, you will get to a place of equilibrium. Once you start eating more food, the binges will stop, and so it's working with the body. And as time goes on and health improves and healing improves, it just becomes more natural and more easy. But in something like this, you're talking about the fact that there is something that is going on that is inbuilt that's not going to autocorrect. And so this is now an ongoing, lifelong thing. And it's sad when you hear me, when I hear you talk about that, because I have a lot of clients who have anorexia who are like, I wish I had that. Like, I wish I didn't get hungry. I wish, and I'm like, I don't think you understand what you're wishing for here.
Yeah. Yeah.
And so with that, so it would then be medications that are already in existence that are then helping with appetite?
No, I mean, I think we don't have the answers to that yet. I mean, they recommended some medications like for off-label use, right, that calm sensations in the GI system, but they're looking at and they're studying that there may be hormonal imbalances, right? That these people may not have enough hunger hormone, and the fullness hormone kicks in too early, right? So maybe there will be treatments on the biological level at some point, but as far as I know, there's nothing yet.
Yeah, very much in its infancy. Yeah, I would be interested to find out, like, are there genetic abnormalities that are then connected to that as well? If from day one, someone just didn't have good hunger feedback. Yeah, and even then, like, what's totally biological versus some developmental, like, the training I'm doing with Nancy Zucker, she's looking at some early developmental factors. And, I'm remembering this slide where she looks at GERD in infants can be a turnoff to eating. And the second one is a muscular issue, like a low suck reflex on the baby, right? Maybe the baby's not getting enough milk and it kind of gives up, Yeah. Who knows? And then the third thing on the slide was respiratory issues and babies who are congested, right? May choose to breathe over eat. Yeah. Right. And so who knows whether it's purely genetic or there's like some very early developmental things that happen that influence it, or more likely some combination. Well, even in adults with anorexia that I work with, it's easy enough with enough time to cut the ties between the feeling of hunger and seeing that as a message. Right. And so you are like, okay, I experience these various sensations, but I do not connect them with hunger. And if that has happened from as long as you can remember, then yeah, it can be very easy to say, hey, I just have no hunger drive whatsoever, because yeah, you haven't made that as association.
Yeah.
So the final thing I wanted to ask, you wrote an article for Very Well where you talked about cognitive remediation therapy with anorexia, and it was just something I hadn't heard of this before and just thought it was quite interesting. So I wanted to have you be able to share it.
Yeah, so that's cognitive remediation therapy, and it's another exploratory treatment that's being studied for anorexia. And it's basically looking at, so individuals with anorexia get kind of rigid in their thinking and don't have cognitive flexibility. So the thought is to try to build their cognitive flexibility and doing it outside of something about food, right? So rather than having sessions or trying to push them to eat foods that they're afraid of, that you focus on their brain patterns instead and try to build flexibility in these innocuous tasks. So when I think of that, I always think of the Wisconsin card sort, which is a neuropsych test that at one point I was taught to administer. And it's this card sorting task where you just put out these cards and you don't explain, and the person has to sort them, and like they all have different colors and a different number of items and the different type of item on the cards, and you don't tell them what the rule is. So someone eventually figures out that they're supposed to sort them according to, let's say, color. And then as soon as they get it right, then you change and they have to sort it by the object on the card. And it takes a while, and people who are very rigid will continue to like stick to the color, even though you've told them they're getting it wrong, right? And so they don't have this flexibility, and that's like this set shifting. And so like a problem in older adults who have dementia or cognitive problems, but the same kind of thing is exhibited in people with anorexia. And they don't know if it's premorbid or if it comes about with the illness, but there's some research showing that you can train them to be more flexible in their style of thinking. And then the hope is that would translate to being more flexible around eating.
Nice. Yeah, it really, when I read about it, I was like, okay, that makes a lot of sense, because obviously the rigidity is, as you say, it's like rigidity in all aspects of life. It's not just around food. It's amazing how much people get into the rituals and the patterns and the OCD type behavior connected to everything, not just food.
Right.
And so what is, in terms of the research, where are they at with it? What have they been able to demonstrate, or it's still in its real infancy and they haven't shown anything?
Yeah, I mean, I'm not super up on the research on this. I've attended some presentations, and it seems like there's some early evidence supporting it, but it's not been, it's not, first of all, I don't think it's ever been a standalone treatment, right? It would be a supplement. So you can't just do that as the only treatment. But it can't hurt for, families to also do games that involve these types of flexibility. And I think if you were to search cognitive remediation therapy games, that, you can come up with activities that can build flexibility. So it can't hurt to try. I don't think there's, like I said, I'm not totally up on the research, but I don't think there's major studies at this point, but it's promising enough that they're continuing to explore it. And the bigger thing is it's not really disseminated yet in a big way. It's like, I don't have a manual that I could start to do it. Yeah.
Yeah. Okay. Well, I mean, it at least makes real good logical sense about why this would be helpful. And in a sense, I've been trying to do this with clients anyway, where it's like, okay, let's see if you can have times where you move around the point at which you're exercising in the morning, or you have days where you're not exercising in the morning, or you're having your snack an hour earlier, or whatever it may be. And so, yes, it's often more focused on the food and movement side of things, but even like bringing in new hobbies is part of this as well. Like, okay, normally in the afternoon you're doing this, but now you're going to start playing guitar or playing drums or playing clarinet or whatever it may be. And I think that has the benefit of dealing with the flexibility piece, but also the benefit of we're now creating more enjoyable things coming into your life, which is in support of, okay, I want to keep recovering because there's more things that are enjoyable in my life as opposed to everything is just fallen by the wayside and what am I recovering to?
Right. Yeah, I think building the flexibility is important and helpful. And so hopefully we'll learn more about cognitive remediation therapy and be able to incorporate it a little more.
Nice. Well, yeah, I will definitely be looking out for more research in that area. And yeah, thanks for flagging it up and making me aware of it.
You're welcome.
Well, look, it's been wonderful. I think we've got to cover a lot of information. I think it's been very practical in terms of the conversation and what people can take from it. Where should people be going if they're wanting to find out more about you, Lauren?
So my website is eatingdisordertherapyla.com, and I have a lot of articles on there and resources, and I'm also the eating disorder expert for Very Well. So one of the articles you referred to is there, and I've also written, I think, like 100 or more articles for them on various topics.
Nice. All right. Well, I will put all of that in the show notes. And yeah, thank you so much for coming on. This has been great.
Thanks so much for having me. It was fun.